We've learned something profound about what's sometimes called the plasticity of the brain.
That the brain is malleable, is able to change. We can take that up and scale that up to levels where it's actually changes in the brain circuitry, how brain regions are communicating with each other over time and as a result of environmental influences. We think of it in changes in synapses, how these neurons are actually touching each other and communicating with each other.
And we know in depression that the number and the strength of these interconnections decreases. With ketamine, we see a regrowth in the interconnectedness and number of these synapses to connect with each other.
We think that one of the things that ketamine does that helps to explain its antidepressant effects is help the brain to regrow the synapses, the connections between nerve cells.
So we think that we're actually targeting a different system in the brain than typical antidepressants are targeting. And that may be why ketamine works so well, even for patients who have not had success with a number of different standard antidepressants.
There's evidence that ketamine can have very rapid onset of effects in neuroplasticity. We think that this may open a critical period where now the brain is more plastic, both at the cellular level, but possibly even at the functional level, where we can start to work to change people's reference of thinking or their ability to respond and adapt to new social or environmental stimuli.
With ketamine, what we're doing is pinging the brain and triggering the brain's resilience mechanisms to promote the maintenance of healthy circuits in the brain. Ketamine can help you with the part of depression that involves reducing the symptoms of depression, but people need psychotherapy to help make sense of what that change means for them in their lives. So we think of ketamine as part of treatment, but not the entire treatment.
When you watch patients get treated, it's really exciting because patients come in clearly struggling, clearly suffering, and you can see a change on their face. And when you think about the average amount of time that it takes for a standard antidepressant trial to work, it's 2, 4, 6, 8 weeks. For some patients, it can be an hour with ketamine.
Ketamine was approved by the FDA in the 1970s. While it's been used for decades in hospitals during surgical procedures, ketamine is now being administered for treatment-resistant depression, extreme anxiety, post-traumatic stress disorder, and chronic pain.
Yeah, and it's important for people to understand what ketamine even is, and there is a lot of stigma around ketamine as well. And we're going to see more and more of these clinics pop up. So I want people to be educated as to what is really going on here and also what to look out for if you decide to go to one of these clinics, because there are some things that you really need to know before you do this. When people have depression, aside from psychotherapeutic intervention and CBT and all the interventions that are non-medication, one of the go-to strategies is the SSRI, right? We've talked about Prozac, Paxil, Zoloft. Those are the pretty common medicines that are prescribed for depression. Now, unfortunately, Kyle, only about 47% of people respond to an SSRI, right? I mean, that leaves a lot of people that don't respond to an SSRI. Now, what happens is, if someone tries multiple SSRIs or SSNRIs like Cymbalta or Pristiq or venlafaxine, these are very similar, but if someone doesn't respond to 2 or more trials of different medicines in this class, they're considered treatment-resistant depression. The medicines aren't helping them, so they're going to fall into that category of people that just really, no matter how many of these medicines you throw at them, it's just not helping, right? So that leads us into this population of people that need something different, right? And at this point, psychotherapy didn't work, the SSRIs didn't work, so what do? Now we go to that second line of treatment, right? And when we look at the SSRIs, I mean, this is fascinating, right? You look at the SSRIs, and SSRIs fall under the theory that the monoamines in the brain, now a monoamine is just a fancy word for dopamine, norepinephrine, and serotonin.
Okay.
3 neurotransmitters, right? There are other monoamines, but those are the basic monoamines that we try to change the levels of in the brain to facilitate happiness, if we can. So when you're taking an SSRI, for the most part, you're dealing with the monoamines, right? Now, in neurology and psychiatry, for decades, we've known that there's something very interesting about a different neurotransmitter system, and that neurotransmitter system is called glutamate. Glutamate works off of a receptor called the NMDA receptor, and that's really just, as long as you know that, NMDA receptor. This is a completely different pathway than the way that the SSRIs work. Now, what scientists realized in the year 2000, when they actually did studies on this, we're going back 20 years almost, they realized that if you block the NMDA receptor with ketamine, you get this incredibly profound antidepressant effect very quickly that was shown to last over the course of days to several weeks, even months in some studies. So ketamine is used, and it's been used widely, and it's been proven to be very, very safe physically. It's a very safe anesthetic. And the reason why it's very safe is because it doesn't suppress your breathing. So anesthesiologists love it. They say, hey, this is a medicine that we can use. It's very safe. So it's used for anesthesia all the time. Now we're realizing as researchers that sub-anesthetic doses, meaning doses that don't put you to sleep, but very minimal doses, help tremendously with depression, profound changes in depression. So that's why we're seeing ketamine pop up in ketamine clinics, because delivering it intravenously at a very low dose reverses depression, at least temporarily for now.
Ketamine is a medication that's been around for approximately 50 years, that's been predominantly used in the past as a general intravenous anesthetic. During the last decade, it's been studied for the use in complex regional pain syndrome. Double-blind, placebo-controlled, randomized trials have demonstrated the efficacy of ketamine in treating complex regional pain syndrome. These are rigorous studies that have been performed at several centers around the world, demonstrating how ketamine can have dramatic results in treating patients with complex regional pain syndrome.
How does ketamine work for chronic pain? First off, when we say the word chronic pain, that can refer to many different types of pain. What happens, studies have shown, is that patients with chronic pain have decreased neurons and synaptic connections, in particular in the prefrontal cortex and the hippocampus. Ketamine seems to go in there and increase the activity of brain-derived neurotrophic factor, allowing for neurogenesis and synaptogenesis in those areas that have become diminished over time from chronic pain. The other factor is the pain receptors in some forms of chronic pain have seemed to have gotten oversensitized or hypersensitized, meaning they're much more reactive to receptors or stimuli than the normal receptor. Ketamine actually goes in there, in particular in the NMDA receptor, and stop the activity of those hypersensitized or wound up pain receptors. So those are two mechanisms of how ketamine may be working from a biological / biochemical level on pain.
All right, so we're going to do a little testimonial here on the low-dose ketamine, and so basically, you came into the emergency department tonight. You was having severe pain in your back, and it's on both sides, right? The pain's on both sides.
Yes, sir.
Your pain started somewhere between 8 to 10 out of 10, so we went ahead and gave you 1 of Dilaudid and 30 of Toradol IV, and your pain went from 10 out of 10 down to 8 out of 10.
8.
Around 8 out of 10, okay, all right. So we decided to do the low-dose ketamine. I used lean body weight. I did 0.25 mg per kg. It came out to be about 25 milligrams. We ran it in over 20 minutes. And so I walked back in the room, and tell me about your pain.
I have no pain.
Your pain's completely gone.
Yes, sir.
And when was the last time you were completely pain-free?
I can't remember when the last time I was pain-free.
You've had this low back pain since
2006.
2006. All right. So I don't know how long this benefit's going to last. I've called some people back at times and they said I'm still having some improvement a day or 2 or 3 later. So I'm hoping that's what's happening here, going to happen here. You haven't been able to get a good night's sleep, you said,
Yes, sir.
for quite a while.
Yes, sir.
So now get you setting up. Are you feeling any pain?
No, sir, I'm not feeling no pain.
All right. So you have zero pain. And what were you telling me a minute ago?
If I could have this done when I have pain, I would rather have this any day of the week. I have not felt like this in years.
All right, fantastic. So the tightness in your back, the pain that was going on in your back is all gone. So the ketamine is an NMDA pain receptor blocker. And like I said, I'm going to give you a call probably in a day or two and just see if how long the pain relief has lasted. But not everybody has this dramatic response. A lot of times it just takes it down 2 notches on a scale of 10. But you going down to 0 out of 10, from 8 out of 10, that's pretty dramatic.
So for certain types of pain, ketamine can be really useful. In particular, for things that are caused by neuropathic pain, meaning nerve-related pain. So for example, if someone has fibromyalgia or post-herpetic neuralgia or trigeminal neuralgia or complex regional pain syndrome, that's where the ketamine can be really more effective. Versus if someone has like osteoarthritis and bone-on-bone degenerative joint disease. Ketamine doesn't really seem to be as effective in those cases. You may be wondering, well, why not? Ketamine works by going into the central nervous system and resetting hypersensitized pain receptors. So sometimes pain receptors can become overactive, and even like a slight touch will be extremely painful. That's typically related to hypersensitized pain receptors. One of the things that ketamine does is works on the NMDA receptor by blocking activity of that receptor. And the end result is kind of resetting the pain receptors, which is why we called ourselves Reset Ketamine, because we're going in and resetting those pain receptors. So just to know that there's many different types of pain and many different types of chronic pain and many different etiologies or reasons why that pain is happening. So it's a very diverse range of types of pain. The more effective ones are where it's related to nerve-related pain as well as chronic pain receptors that have become hypersensitized.